Manisha.
Simplifying bacterial keratitis treatment with higher concentration levofloxacin. As Dr. Vasavada in his talk, when he was telling us about the ideal antibiotic to choose, we know that the fortified antibiotics have been the mainstay whenever we were dealing with the moderate to severe bacterial ulcers. But they have their own problems like concentration, like chances of contamination, and so on. So when we got this drug, we were quite excited that this may be one of the solutions. And before saying that, I thought clinical pictures and find out from our
I think we are losing connection from Manisha.
um, it's there now.
Your video is getting freeze.
You can stop your video, Manisha. I think that will help a little bit.
Okay, should I start?
Yeah.
Thank you. Is it better?
Yeah.
Thank you. So this 71-year-old female presented with a 10-day history of pain and redness in this eye, with history of keratoplasty around 16 in 2016. That's around 4 years back. It was a typical infiltrate which was present at the host graft junction, a 3 × 3 millimeters. All the sutures had been removed, but there was a tag which we could see that it was still there. So when this came, we did the normal, what we do for these patients. A corneal scraping was sent, and it came out to be having gram-positive cocci. In routine, in such patients, we normally give fortified, but this time I wanted to give a monotherapy with a higher concentration, what I like the word a pseudo-fortified levofloxacin. So we started this medicine, and the patient did start to respond within 2 days. So by day 3, the patient had resolved. The infiltrate had started to resolve, started steroids to prevent the graft going into rejection. And by day 10, we were quite out of the woods, and the vision resumed to a lot better than what the patient had presented with. This gave us a little confidence in the new drug which was there available to us, and without any problem of fortification at our end. Then came this patient who had this 1 week history with history of grain injury. And this was a small infiltrate which was there in the center. We did a corneal scraping. Initially, I thought it may come out to be fungal, but it was KOH negative on the smear. And then we had to start an antibiotic. And with my previous experience, I started the patient again on monotherapy, levofloxacin 1.5%. And the patient did respond within a week. This was another similar case who presented with trauma history, and the inferior infiltrate was there, a moderate size, more than 4 millimeters, and started the patient on levofloxacin, and the patient did respond well to the medication. This was a one-eyed patient who was not even from Delhi, had undergone a keratoplasty along with the retina surgery, that a PPV was done with the nucleus removal, and 8 years back. Patient was doing quite well for some time, used to come for follow-ups and go back. Now came with that bad foreign body which was there inferiorly. Removed the foreign body, but definitely scared that because it did look that it had some infection around, and the foreign body removed was also plated on grams on blood agar and sent for cultures. Started the patient on levofloxacin with the loading dose, followed by an hourly application for 24 hours, and made the patient stay with us in the ward. And the patient, after 24 hours, was doing well, and then only sent back to his hometown. This was another case of a failed graft. We see quite a lot of these failed grafts who do not want a resurgery, but they do develop infection. So when such a case happens, now I started them with monotherapy of levofloxacin, which they can continue for a week whenever the infection subsides, and we stop them. This was a moderate, I would say a little severe infiltrate which had come up to us, this 80-year-old female with 5 days history of pain and diminution of vision. And when the patient presented, we did the gram staining, and it did show gram positive cocci. Started the patient on the levofloxacin, and the patient had started to respond. The patient was from a secondary center and went back to the secondary center for follow-ups, and I was told that the patient was doing well. The patient already had some history of viral keratitis, so it was like a bacterial on viral keratitis. The oral antivirals were continued, and steroids started once the infection had started to resolve. And we had the culture report of streptococcus with us. These were all adult patients. Then came this 4-year-old male child with a 1-day history of pain and diminution after 1 week of uneventful cataract surgery in this eye. The left eye cataract surgery or the other eye had been done 6 months back, and the child was doing well with that. At presentation, that is on the after surgery, the patient's vision had gone down to 1/60, and the slit lamp examination, if you look at it, it suggests that the section is not looking a very well opposed wound, which I would like after a cataract surgery in a child. The corneal findings did show edema, but at that area there were intact sutures which could be seen. There was a lot of reaction which was present in the anterior chamber, and it was like a fibrin which was coming up. But we all err on the side of infection at that point. It was quite in the evening. To get the scraping results, it was quite difficult. So we planned for an EUA next day. And to start with, we started the patient with levofloxacin, along with, I would say here, I also gave the patient on amikacin fortified medication, which we normally give for section infection, thinking of nocardia if it was there. The patient started to respond, but if you look at that day 2 picture, the patient was doing better. The fibrin or the reactionary part had started to break up. You see over here, the patient also had iris bombay because the AC was shallow, continued the patient on antibiotic, and started the patient on steroids at this point as well. And within day 4, the patient had started to respond, and we looked carefully at the incision site. The incision was also looking much more healthier. And I think we had one meeting, if Dr. Prashant would remember, that at that point, I was still treating this patient, and then it was discussed that we should just continue with monotherapy. And we stopped the amikacin, and by day 4, we just continued the patient on monotherapy of levofloxacin. The patient did well, along with the other treatment which was given with it. The iris bombay settled, and as the days progressed, within a week, started to do well. The pediatric ophthalmologist, my colleague, was definitely happy. And after that, even the other patient which we saw, she had herself started the therapy. And then after that, we stopped giving the combination therapy in such cases. So, and by 2 weeks, the patient had done pretty well and was looking like a normal post-op case, which we see in pediatric cataract cases. Then came this 21-year-old male who had complaints of pain and redness for 2 days and optical penetrating keratoplasty. This is the pre-op picture when it was done 6 months back for this adherent leucoma. This is the current state when the patient presented with a 2 days history of pain and redness. If you look at the host graft junction, it is well opposed, but definitely there's a suture infiltrate which is there. A hypopion and stromal edema with DM folds present. The fundus was normal here. We did what normally is done, removed that loose suture and cultured and did the scrapings, found out whether we were dealing with a bacterial infection over there. Sorry, it was a gram-negative bacilli which had come out, and we thought we might be dealing with the pseudomonas in this case, and we started the patient again on this combination therapy with hometropine with this. The patient came out to have serratia on cultures, both on blood agar, and with continuing the medication, the patient had started to respond. There was another loose suture, which was then removed. The sensitivity report did show that it had sensitivity to most of the antibiotics which were there. Continued the patient on started the patient on steroids along with the antibiotics, and the patient started to resolve with the rounding of ulcer margins as it can be seen, and reduction of hypopion. And within 2 weeks, the patient was doing much better. If you look at this day 12 picture, it is responding to treatment, reduction in edema, but definitely that area is scarring up. This is in a nutshell. If you look at the clinical picture and the course of these suture infiltrate, this is what it is. Patient is still under follow-up with us. So these are some of the cases which I had seen, and this is just a clinical, I would say, a nutshell of one of this 17-year-old patient who developed, just on clinical picture, it looked like a wreath-like pattern and nocardia. This again was treated with monotherapy, 1.5% levofloxacin, and did well within 10 days. So this is the collection of all the cases which we have done. Now we have 10 cases, documented cases, where we have seen good response in bacterial keratitis with 1.5% levofloxacin. So I would just say that most of the identified bacterial keratitis, they did show improvement with the drug mentioned, but none of the cases had to undergo any additional procedure, tissue adhesive or therapeutic penetrating keratoplasty. Saying that, I would say that most of our cases had small to medium-sized infiltrate. In fact, the last ones were the ones which were most severe. And barring the Serratia case, the others did have gram-positive bacteria only. So now after Serratia case, I still feel that it's good for gram-negative as well. But for gram-positives, definitely it is a good monotherapy to be given. So to conclude, I would say that eye drop 1.5% levofloxacin in loading dose, and then the 2-hourly dose can be an effective treatment modality as a monotherapy for bacterial keratitis, although large samples need to be studied. And further, long-term randomized trials need to be done to find out the efficacy in all types of bacterial keratitis if we have to propon it for that. I would like to acknowledge the contributions made by Dr. Gunjan, who's my fellow and had contributed immensely in this collection of cases. Mukesh, who's an optometrist and helped me with all the pictures which are there, the cornea services at our hospital, and the laboratory services of Dr. Shroff's Charity Eye Hospital. Thank you so much.
I think, thank you, Manisha, for those wonderful set of cases.